Welcome to Infection and Immunity Evidence Explained, a Doherty Institute podcast. I'm Rebecca Elliott. Antimicrobial resistance has consistently been named by the World Health Organization as one of the top 10 global health threats, and it's fair to say the statistics are staggering. Current estimates suggest there are over 700,000 deaths per year due to antimicrobial resistance, with that number expected to reach 10 million by 2050. Antimicrobials refer to a category of medicines used to prevent and treat infections in humans, animals and plants, including antibiotics, antivirals, antifungals and antiparasitics. So what exactly is antimicrobial resistance and what is causing it to become increasingly worse? Well, here to help us answer these questions and, importantly, what's being done to prevent it is Dr. Rod James. Rod is a medical microbiologist who has worked in antimicrobial resistance research and the implementation of capacity building programs across Australia and in low and middle income countries across the Asia Pacific for more than 10 years. Rod, thanks so much for joining me on Infection and Immunity Evidence Explained.
Thank you, not a problem.
All right, let's start with the basics. What is antimicrobial resistance?
Antimicrobial resistance is when organisms develop the ability to become resistant to certain medications which we've designed to attack them and kill them. This can be bacteria, viruses, fungi or parasites, and it really is a mechanism where they protect themselves against hostile environments, and including the medications that we try and treat them with. So they really do build up a ability to prevent these medications working on them, and they therefore be able to continue to cause infection and populate.
That sounds like quite clever. What actually causes them to be able to do this?
They are extremely clever. They've been around a lot longer than we have, and they've developed some very, very sophisticated mechanisms of staying alive, because the environments they live in are often very hostile, so they're very used to developing genetic ability to adapt very well to their environment. So for some organisms, particularly bacteria, they can change their proteins so that the antimicrobials can't bind to them, can't work. They can increase their cell wall thickness. They can create holes in their own bacterial walls so that the antimicrobials get pumped out again, or even release enzymes into the environment around them so the antimicrobials get broken down before they can even get to the bacteria. So they're very, very sophisticated in ways of staying alive. So whatever we try to develop to kill them, they very quickly develop ways of overcoming these medications.
So do all pathogens have the ability to become resistant to antimicrobials, or are some worse than others?
All have some ability. There's definitely ones which we consider more highly mobile to actually produce these resistances, particularly, most people know of Staph aureus or MRSA golden staph. That's been around for many years, very highly resistant now because it has developed a lot of these mechanisms. But other ones, like syphilis has been around for many, many years and is still very highly prone to the antimicrobials that we're prescribed for them. But even fungi can produce these, parasites, viruses. So all organisms do have some capacity, but there are some which we are more concerned about, and they have a higher rate of resistances. Also, a lot of organisms have intrinsic resistance. That's it, even before being exposed to antimicrobials, they're already resistant, just that their protein structures and their cell walls and things, the antimicrobials don't work for them and never would have. So some are definitely in that kind of realm of being highly resistant, while others have remained quite sensitive to these antimicrobials. So are
we more concerned, would you say, by bacteria, or really is it all of them?
Yeah, I think particularly bacteria is the biggest concern. They're the organisms where we're seeing more resistance. There's definitely one new fungi, a yeast called Candida auris, which is highly resistant, and we're seeing that worldwide, having major outbreaks and causing a lot of death and morbidity because of that fungus, which is just a Candida. So although we do concentrate on bacteria, with the increasing fungal use, we are seeing the fungi causing some problems as well. We always know with viruses, there's a lot of resistance in those, but we don't often use many medications to treat them because our body's very good at getting rid of a lot of those viruses already, especially the respiratory viruses, but all organisms do have some propensity to do that.
How do we detect antimicrobial resistance?
Particularly with bacteria is the main one we detect on a routine basis. So it's really, we have a swathe of different ways of doing it in the laboratory these days. We're getting very sophisticated. The old technique is really just to get a plate of bacteria, agar plate, and you plate the bacteria across it, and you impregnate some paper discs with different antimicrobials. Put them on that plate, and if the bacteria are resistant to them, they'll grow right up to the paper disc. If they're resistant, if they're susceptible to that antimicrobial, there'll be a ring of inhibition around it. We can measure that ring and work out whether they're going to be susceptible to that antimicrobial or not. We're now developing some more techniques, so there's more moving into rapid technologies where you can do a whole lot of different microorganisms with different antimicrobials within a machine, which takes about 8 hours. It's very, very fast. Or we could actually go to DNA testing where we can actually look for the actual genes that we're concerned about for some of those more common bacteria. Here at the Doherty, we're doing some more interesting things. So we're doing whole genome sequencing. That's where we can actually do the entire bacterial DNA sequencing and actually for all the different resistances that bacteria might have. So we are becoming more sophisticated with being able to detect these resistances.
We heard a lot about genomic sequencing during the COVID pandemic, of course. Can you explain a little bit how that works for antimicrobial resistance?
Yeah, so really we use it a lot, particularly for outbreaks, which is why we saw it in COVID. So we can really detect whether these, particularly with bacteria, if they're coming from a point source, so if they all have the same genetic kind of disposition, all the different resistance profiles are the same. So we can say, well, particularly in a hospital, is it a hospital outbreak that's causing this resistance of bacteria to be more often, or is it a community spread where they're kind of coming in the community with all the different resistance profiles? And it really helps with our outbreak response and our response to those organisms. So it's very helpful to understand, I guess quite rapidly, where these organisms potentially might be harbouring a source, so we can go and try and prevent that from spreading any further.
So how do you go about actually getting those samples? Is it from people? Is it from the environment? How does it all work?
So mainly from people. So we can do what's called just routine collection. So if a person's sick, showing signs of infection, we'll collect the normal sample. So urinary tract infection, we'll get a urine sample, respiratory tract infection, sputum, so the septic, a blood culture, and the organisms will be detected in just routine screening. If we then are worried, we can actually do what's called screening, where we actually purposely go and collect swabs from people to actually see if they're harbouring these organisms, these resistances, even if they themselves might not be showing signs of that infection. So we can do some kind of sample screening to see if the organisms are being harboured within the community. We can do environmental screening where we do swabs of the hospital environment, the curtains, the patient's beds, the walls, to really see if there is a point source maybe within the hospital. Often we find them in hospital sinks or drains, which is a nice moist environment where some of these bacteria can harbour some kind of node of ability to kind of stay within that hospital environment.
So what then happens if you do detect an outbreak in hospital? What happens next?
So we now try to have an outbreak response team to kind of, I guess, get them to come together and decide what to do. So really what we then concentrate more on is screening, making sure we find out how many patients are involved, who's involved, cohort them so they're not spreading that bacteria to anyone else in the hospital, and really implementing some infection control techniques. So making sure that if they can, isolated in their own room, with their own bathrooms, using contact precautions, so gowns, gloves, masks, to make sure that the staff aren't spreading that organism around as well, and really trying to treat those patients as well as best we can so that we can reduce that burden. But really it is that whole idea of infection control, working with the microbiology team to really make sure that these patients are being detected and looked after in the best way so that we're not spreading those organisms around the hospital.
So the Australian Commission on Safety and Quality in Healthcare recently released AURA 2023, which is the 5th Australian report on antimicrobial use and resistance in human health. What were some of those key findings?
Yeah, so it's actually quite interesting. So we're seeing some areas of improvement and some areas of stagnicity, I guess, particularly in the hospital environment. We're still seeing very high rates of antimicrobial use. Australia has one of the highest rates of antimicrobial use in the world, and even after many years of these reports coming out, we're not seeing a great decrease in use within this hospital environment. And with that, we are seeing increasing rates of resistance and being quite high and being maintained. Particularly in the hospital environment, we're also seeing that the antimicrobials are being used. Again, we're finding areas like respiratory tract infections, surgical prophylaxis, where there's high rates of inappropriate use, which has been seen across the board. And even in most hospitals, about 23% of all antimicrobials being prescribed are deemed inappropriate.
So could you just explain that a little bit further? So you're saying that if someone presents with a respiratory infection, for example, they might be given an antimicrobial to prevent potentially a bacterial infection. Is that what you mean by inappropriateness?
So inappropriateness is interesting. So we look at the entire patient and the antimicrobial being prescribed. So we have very good guidelines in Australia for most conditions these days. And if we really see that making sure that the patient has the right antimicrobial to start with, it's the right dose, it's the right frequency, the right route, and for the right duration and length of time for being prescribed. So any of those could, if they're not being prescribed appropriately, cause either patient harm, not treat the infection, or increase the chance of producing antibiotic resistance. So we really do try to make sure that the right patients are getting the right drugs. And same thing is they might be getting a antibiotic when it's a viral infection. We know that antibiotics don't work for viral infections. Or if a patient's extremely septic and maybe the resident or the intern didn't realise so much, prescribed a nice narrow spectrum targeted antibiotic, and we think, well, actually, no, that probably should be something broader and something a bit more appropriate for that patient. So we might increase the dosage or the spectrum of activity of the antimicrobial to make sure that they're being covered. So, yeah, we're trying to make sure that each patient, when they receive an antibiotic, are receiving the correct one for them.
It sounds like a really difficult balancing act. How do doctors and pharmacists, how are they able to manage this?
Yes, it's extremely difficult. And I think, this is why we're not seeing a great amount of change very, very quickly, because it is a real, as you said, balancing act where the doctor is really concerned about the patient in front of them. They want to make sure that patient gets the best care. If they're a bit concerned, it's a bit easy to maybe jump for one of those high shelf drugs just to make sure that they're covering all bases, where we really know that maybe they probably don't need to in Australia. We don't have those huge rates of infection, of resistance that we are seeing around the world. And really looking at the other side of things where, we do have to protect society and make sure that everyone is able to have these antimicrobials lasting well into the future. So maybe inappropriate prescribing now could prevent someone getting the correct antimicrobial in the future if they're becoming resistant to those down the path. So it's a balancing act of trying to make sure the patient gets treated correctly, and if the patient is getting treated correctly, then that's a much less chance of developing resistance. So that's why we do try to say, follow the guidelines, make sure you are looking at the patient each day and making sure they're on the right drug.
The National Antimicrobial Prescribing Survey is a Victorian initiative that you lead that's just celebrated its 10th anniversary, so congratulations on that. Can you tell me a little bit about what this survey does?
Yeah, so it's something we're very, very proud of. We did some research about 10 years ago, or 12 years ago now, where we really went out to hospitals, went to private hospitals, public hospitals, big hospitals, rural, regional hospitals, and really worked out what they needed to support them for improving the antibiotic use within the hospitals. And what they really wanted was a tool. They wanted something which was standardised, which they didn't have to create themselves, which they could use to monitor their own use of antimicrobials in the hospitals. There was a few tools floating around internationally. We had a look at those, but they didn't really fit the Australian way of life, where we have very, very small hospitals, very large hospitals, and we really wanted to make sure there was something which was able to be used across all those facilities. So we created a tool which was called the National Antimicrobial Prescribing Survey, where hospitals can look at on either kind of very, very short period of time, so 1 day or 1 week, and go through their entire hospital and audit every single patient on an antimicrobial to really get some nicely in-depth information about that patient. So we'll look at what antimicrobials were being prescribed, what the indications were, collect the dose, the route, the frequency, look if they'll comply with the prescribing guidelines, and we also bring into if they have an allergy or if they've got some microbiology results. So really have a look at the entire patient holistically and then decide, is this patient receiving the right antimicrobial, and then judging that either inappropriate or appropriate. So we get some really granular data on what's happening in that hospital.
So does that mean that you can monitor that in real time?
So as I said, this is real time. So again, our survey, and it's an online portal. You enter your data, and it does all the analysis and produces these lovely dashboard reports as soon as you finish entering the data. So on that day, you do the audit, you get all your results back. That's what we really wanted to target, so that people could do some interventions, which are really based on data which is available at that point. So then they can go back to their different specialties, the different wards, talk about areas of concern. Again, often we find it's surgical prophylaxis, or it could be gastroenterology, or it could be respiratory. Each hospital is slightly different, so therefore they can target it for their own facility where they want to look at some interventions to try and improve prescribing in their facility. With that success, we've also then realised that, again, surgical prophylaxis was one of the major issues, so we created a whole survey on surgical prophylaxis, and also we've now moved into aged care and looking at even a more dedicated one just on antifungal prescribing. So it's a platform where we can get a lot of information about lots of different aspects of prescribing very, very quickly and clearly, and provide that data back to those services immediately.
And what are some of the sort of significant successes you've seen out of a program like this over the years?
Yeah, so I think the main thing is its adaptation. So it's a voluntary survey, and we started off with 32 hospitals to see how it goes, and now over 700 hospitals in Australia have provided data.
That's
and
huge.
Well over, I think, getting close to 2,000 aged care facilities have joined the survey. So that's and that data gets fed into an oral report. So we really can see that we're starting to build up a national database of surveillance, and again, with 10 years of data, we can really interrogate that data really well. So the database is open up for any researchers. So we've had people who look at just paediatric prescribing, just haematology prescribing, sepsis prescribing, surgical prophylaxis, and then be able to actually work out what are some interventions that can be extremely targeted to try and improve prescribing in those areas. With limited resources in health, it's just too big to do all of antibiotic prescribing. So these surveys really able to hone in and make sure that people are using those money and resources in the most accurate way possible.
So can you tell me a little bit about the concept of antimicrobial stewardship? What does it mean?
Yep, so antimicrobial stewardship is a systematic approach to ensuring that all patients receive the most appropriate antimicrobials for them. So it's looking at, again, those metrics of making sure it's the right antimicrobial, the right dose, the right frequency, the right duration, and ensuring that over time, that if the patient's characteristics change, that we change those antimicrobials quickly to make sure that they're on the most effective treatment for their condition. It's often created by a team of experts, and we might have infectious diseases doctors, microbiologists. We now have pharmacists, which are designated antimicrobial stewardship pharmacists, and it can involve infection control nurses or pretty much anyone in the hospital who wants to be or concerned about antibiotic use. And it's a way that we monitor and improve our prescribing in our hospital by education, by auditing and feedback to prescribers, so they ensure they know what's happening in the hospital.
So is this happening at all hospitals around Australia and globally, or where does it get implemented?
So it initially got implemented in hospitals who were concerned about their prescribing, and particularly by larger facilities where they were seeing increasing resistance. At about 10 years ago, so when the NAPs first started, the Australian Commission on Safety and Quality in Healthcare really put out some recommendations that antimicrobial stewardship programs should be instigated in all hospitals, and soon after that it did become an accreditation, a requirement for hospitals. So for Australian hospitals, every single hospital has to have an antimicrobial stewardship program in place to pass accreditation, and that includes private hospitals. Similar things are coming into aged care, where it's highly recommended that stewardship programs are in place. So we are seeing these kind of programs being more adopted widely. As you can see globally, stewardship programs are becoming more common and popular in these particularly Western countries, and definitely in the Asia Pacific region now. There's a greater interest in these programs where we can help out as well.
How important are these programs? They sound incredibly important.
Yeah, I think they're really important because, particularly without audit and feedback and understanding the issues, we just don't know what to do about what interventions to implement, how do we go about improving things. So I think a stewardship program being set up in a very systematic way, where they can audit their facility, work out what indications, antimicrobials, what units are performing poorly, and really design some interventions around those and feedback to those facilities. And having that, I guess, a team which other physicians can ask to come and help as well, because we know that particularly with increasing resistance, with a wide range of antimicrobials on the market now, choosing the right one is a bit of a science, and often having a team which is more expert in that field is really good, so that people can actually ask advice from this team to really help them improve their own prescribing when they do have complicated patients.
In 2021, the Doherty Institute was formally designated a World Health Organization collaborating centre for antimicrobial resistance. What's the role of the centre?
Yeah, so we really are there to provide education and help build capacity within the region. So countries within the region are able to approach the WHO for help, and then they will look at the collaborating centres. So they often come to now the Doherty to help out with that. So it really is providing education, so we can do seminars, we can do some training, either in country or bring them here to do the training, and really to improve their understanding of antibiotic resistance, how they can detect it, how we can improve that, and stewardship as well, so how we can set up stewardship programs in these regions. So with that, we've produced some outbreak documents, some surveillance documents, which are able to be then distributed through these countries. We've done some in-country training and some seminars. We have improved the ability to detect these antimicrobial resistances by improving laboratory techniques and really enhancing their understanding and ability to quickly determine antibiotic resistance and provide outbreak responses to those.
So you've got an outbreak in one certain country. How does that affect other countries, and what role does international cooperation actually play?
Yeah, well, unfortunately, bacteria don't understand international borders, so they're very happy to hop on a plane with a person and come along. So we really are seeing a lot of transfer of resistances between countries with high rates of transport. We are concerned about patients coming in from other hospitals in the region. We know there's high rates of resistance in these hospitals, so if they are coming in, being transferred back to Australia, we are concerned that these are higher risk patients. So we do like to have a regional approach to antibiotic resistance, particularly with the Department of Foreign Affairs and Trade, who do support a lot of our activities as well. So we really want to ensure that the region has a very consistent approach to antibiotic resistance, detection and prevention, so that we don't have major outbreaks being transferred across borders. We do want to see, in countries where there's limited resources, to try and improve those resources, build up laboratory capacity so they can detect it, improving infection control practices and antibiotic stewardship practices. So we really want to make sure that the region is prepared for the upcoming amount of resistance we might be seeing, because there is forecast that resistance will be increasing in the region. So make sure that we can have the best ability to prevent that and act on it when it does occur.
So I mentioned in the introduction that the World Health Organization is predicting that there might be up to 10 million deaths from antimicrobial resistance per year by the year 2050, which really is quite scary. Why does it appear that antimicrobial resistance is increasing?
Yeah, I do think it is more just a perception. So antibiotic resistance has always been around. It's a very natural occurrence. All bacteria naturally produce resistance to stay alive, as we discussed earlier. But I guess in the early days of antibiotic being produced, particularly through the 60s, 70s and 80s, we saw a huge range of new antibiotics coming onto the market. If bacteria became resistant to one antibiotic, we usually had 5 or 6 other ones that we could use, so it wasn't that big an issue. Unfortunately, as antimicrobials become more resistant to all those other drugs, drug classes, we're not seeing that same amount of new drugs coming onto the market. In fact, in the last, say, 20 years, there's been really very, very few new classes of drugs that have come onto the market. So we're not seeing that same ability to have a whole new shelf of drugs, which we used to have back in the 70s and 80s.
And why is that?
It's really because the drug companies, first of all, aren't that interested in producing new drugs. Like a cardiology drug, often for hypertension, you might be on it for life. Whereas antibiotic, you might be on it for 3 days, 5 days. So they don't really see it as profitable as some of those other drugs. So, and also to get an antimicrobial onto the market is extremely expensive. And once it's on the market, we try to put it on the shelf and not use it so much so that we don't produce resistance to it. So the drug companies aren't seeing antimicrobials as a highly profitable area to go into. But I also think with more research around this area, we still haven't found a new class of antimicrobial. So we are seeing lots of old antimicrobials come back onto the market, or putting 2 antimicrobials which have high resistance together to try to see if a combination might have some effect. Although these do sometimes improve the resistance profile and be able to kill these antimicrobials, again, because they have seen these drugs in the past, they develop resistance to these much faster. Whereas if it was a new class of antimicrobial they hadn't seen before, that resistance kind of develops a bit slower, which we haven't seen for many years. So looking into the future, we are really relying on the antimicrobials that we do currently have on the shelf. And we really want to try to preserve these for as long as we possibly can, while we do wait for maybe some newer research to find some newer antibiotic classes to try and increase our range of drugs that we do have.
So with that said, what role can we as individuals, when we go to the GP, for example, play in preventing antimicrobial resistance?
Yeah, I think there's a lot more education around antimicrobials these days. And as we said, Australia is a very high user of antimicrobials, so I do think we need to learn not to ask for antibiotics, particularly after the COVID experience. We know that antibiotics aren't used for viral infections. And it really is that idea that we take some ownership on ourselves to make sure that we do some proper infection control, wash our hands, cover our nose when we sneeze, cover our mouth when we cough, so we don't spread our viruses around, don't spread our bacteria around. And that will, in some aspects, stop people going to the GPs to try and get antibiotics when they do have colds and flus and other illnesses. So we really want to try and really protect our communities to make sure that, if everyone's well, then there's less chance of going to the GP. And we saw that during COVID. So during COVID, when we did have those very extended lockdowns, and in the ORA report it does demonstrate this, that antibiotic use decreased by 23% over that period because people weren't getting those bacterial infections. There's good education that COVID was a viral infection, we didn't need antibiotics, and people weren't moving around and spreading their diseases. So we did see a huge decrease in antibiotic use in Australia. Unfortunately, since then, it has bounced back up, and 10% increase since COVID. So we'll probably like to go back to those original levels.
And is that because we are seeing more bacterial infections rise again now, people moving around, or?
I still think probably a lot of it is viral infections. I think a lot of our use in the community could be reduced by people, and really, I guess, not jumping at antibiotics as the first line of therapy. There are, particularly when you have a sore throat or a cough or a sneeze. We do know these are mostly viral infections, and even if they are bacterial, often they don't last very long anyway, and antibiotics don't really help that much. So I think the understanding that majority of infections we don't need antibiotics for in the community, and really rely on your advice from your GP of when to take these, and if it's maybe a watch and see, maybe take their advice and not jump at the antibiotics if you can prevent that.
That is definitely great advice. So looking ahead, what do you see as our future challenges, but also our opportunities in this area?
I think a lot of our challenges we've already described. It's the lack of new drugs coming onto the market. It's that really balancing act between treating the patient in front of you as to also looking after society. And it's going into areas where I guess antibiotic prescribing is a little bit under the radar. So in dentistry, in agriculture and veterinary practices, we really want to try and see if we can improve antibiotic prescribing across all aspects of prescribing, not just in hospitals, not just in general practice. And we do know that aged care sector as well is particularly with the ageing population in Australia, is a big area to go into. And I think the community is kind of behind us now a little bit as well. Antibiotic resistance is getting a little bit more airplay worldwide, so people are understanding that. I think in the past it was the idea that antibiotics might help, but they probably won't do any harm. But now we are saying, well, they probably won't help, and we know that they do harm for a lot of these conditions. So we really want to, I guess, continue that education of the population and really see that we can get better prescribing across all aspects of where antibiotics are being used.
Well, there's some great tools being used there. Thanks so much for explaining those to us today. It's a good message to leave us on. Rod, thank you so much for joining me today.
No worries, thank you so much.
And thanks to all of you for listening to Infection and Immunity Evidence Explained, a Doherty Institute podcast. If there is a specific topic you would like us to cover, please get in touch with us by emailing doherty-media@unimelb.edu.au. That's doherty-media@unimelb.edu.au. If you've enjoyed our podcast, please rate and review on your favourite podcasting app and subscribe if you haven't already. The Doherty Institute is a joint venture between the University of Melbourne and the Royal Melbourne Hospital. See you next time.